Good morning, everybody, and welcome to the California Opioid Safety Network's Accelerator Program Boots on the Ground webinar. Welcome to our first of the Boots on the Ground series, Strategies to Lower the Opioid Supply. Before we get started, we wanted to review some basic housekeeping information. On your screen is the 866 number for WebEx. Please use this if you have any technical difficulties with the WebEx system during the webinar. If you need to reach any of us, please use the Q&A feature. It should be on the right-hand side of your screen with the letters Q and A. Please type in your message. Remember to pick all panelists from the drop-down menu and to hit send so that we can see this message. You can do this at any point during the webinar. We have production staff here ready to assist you with any technical questions, and you can also send any questions related to content, and we'll answer them as we're able to and during the discussion period at the tail end of the webinar. So please do that through the Q&A feature. The chat feature is disabled for this webinar, so you can only use the Q&A feature. So our webinar today, our desired outcomes are for you as participants to understand the scope and source of the problem related to high opioid supply, to be able to describe the range of potential strategies that opioid safety coalitions can implement to reduce supply of opioids in your community, for participants to be able to receive suggestions for implementing strategies based on the experience of other coalitions, and for you to understand the range of available tools and resources to help implement strategies. We will be going over quite a bit of content today. Again, the series of 3 core webinars is meant to introduce and provide a full-scale overview of each strategy area. At a later point in our network programming, we will be providing a lot more detail. We'll do deep dives into a number of these different areas as directed by the interest of all of you. So our agenda today is to go over the opioid supply problem, existing strategies, lessons from the field, the available tools and resources, and then we'll have about half the time to do a discussion with all of you, and we'll provide direction on that at the tail end of our webinar. I would now like to bring on our director, Dr. Carmen Navarez, to welcome all of you.
Good morning, everybody. It's great that you could join us. I wanted to take a moment to just give you a little bit of a refresher on where we're going with the program. You have already participated in one webinar on coalition performance improvement. So we have a whole series that are just working on trying to make your coalitions work better, work faster, work smarter, work more transparently, and with much more impact. So that is the Coalition Performance Improvement Series. Today we're switching gears and moving over into the Opioid Strategy Implementation Series. And this series is the Boots on the Ground series, and we wanted to just start today with the first out of a series of 3. Today we're focusing on supply. We're going to also focus on demand and on the prevention of overdose at different times, at times later in the series. Today's is about practical tools for local coalitions. We're going to have a presentation from Dr. Matt Willis, and then we're going to hear from some coalitions and hear about what they've worked with, what has worked for them, and the lessons that they've learned. And finally, we need to know about you. So we're going to flash a poll at the beginning that we want you to answer, and at the end of this webinar, we're going to send you a survey. The survey is going to help us to understand what else do you want to know about. For the things that we talked about today, what are the areas you want to drill down on, and what are the areas that maybe you don't need to know as much about? Because that will help us to tailor the technical assistance that we give you going forward. So please, you may start to feel tired of the surveys and tired of the polls, but it does help us to serve you better. We know that everybody in this group is facing a problem situation from a different point of view. You have different tools that are available to you. You have different strategies that you're currently using. You have, you're at different points of organizing against opioid overuse and the abuse of other substances. But what we want to do is make sure that we're getting to help you where you're at, and that's the purpose of all of these polls. So please, even when you feel like you already answered that question, we're going to ask you again, and just give us that information. So let me start with a poll to kind of set us up for understanding today. Which of the following strategies is your opioid coalition using to help reduce the supply of prescription opioids? And we want you to, on the right side, mark all of those that apply to you. So A, safe prescribing guidelines, B, decision support tools, C, implementing policies and or protocols, D, provider support or academic detailing, E, drug disposal and take-back programs, F, partnering with law enforcement, or G, other, and you can describe in the Q&A box. So you'll just go over to the right side of your screen and check, using your mouse, all of those that apply to you, and you can put in as many as apply. And we're going to put 2 minutes on the poll. We're about 50 seconds into it, and then we will show you the results in a bit. And you can go into the Q&A box, which is above the poll questions, to write down any other strategies that you may be using to reduce the supply of prescription opioids. So the poll will be over with in less than 1 minute. And we'll keep this open until we run out of time, and then we'll show the results. So let me go ahead and introduce our speaker. Our main speaker is Matt Willis. He is our clinical lead for the California Opioid Safety Network. He is a Marin County Public Health Officer, a primary care physician, and an epidemiologist. He's a co-founder of RxSafe Marin Opioid Safety Coalition and a member of several state opioid task forces. Matt is a real expert here. He is an amazing person to work with. We're very happy to have him helping to steer the road in looking at the Boots on the Ground series and other strategies that we're going to be bringing to you. And with no further ado, I'm going to go ahead and introduce Matt. Matt, you're on.
I just want to make sure technically that is the introduction slide that everyone sees?
Yep, we can hear you and you're
great.
on the right slide.
Great, okay. So I'm confident that this is hopefully going to be high-yield content for you all in working in coalitions. This is really designed to be a series, the Boots on the Ground series, that will answer your questions about what should we be actually doing. Many of us have been working in this space together over the last couple of years and recognize the value in practical conversations between one another around one strategy or another. This is a way of sort of formalizing that process a little bit and accelerating that sharing that we all benefit from. And I'm seeing the poll results coming up now. How exciting. So I can see that safe prescribing guidelines is something that most coalitions have engaged in. Some are doing drug disposal and take back, that's the second highest. Can everyone see the results of the poll, or can only I see that?
No, we can see it. It should be
everyone can see it. Okay, so I won't review the results of the poll then. So we have, there's lots of, looks like there's many coalitions that may not be doing some of these strategies, and some that are and can help the others. So the way we've organized these Boots on the Ground series, as has been alluded to, is really recognizing that any strategy we adopt is going to fit into one of these three buckets. Either we're working to kind of turn off the faucet, if you will, of the inflow of opioids into our community, recognizing that this is largely an iatrogenic problem. This is an epidemic that started in healthcare, and we still have a lot of work to do in terms of reducing the supply of opioids. One important caveat for this conversation is that an increasing proportion of the opioids that are being abused in our communities are coming from other illicit sources. This webinar will not be focusing on those illicit sources, and we can discuss that as our strategies in those areas mature. So today's really primarily focusing on reducing supply within the healthcare system. The Reducing Demand webinar will be, when we do the overview like this, will be really primarily focused on medication-assisted treatment options and also safe and healthy pain management that does not involve opioids. And then when we talk about preventing overdose, we'll be focusing primarily on some harm reduction methods, especially naloxone and naloxone distribution. So today's focus is reducing supply. And I'm going to start with just sort of why are we continuing to focus on the supply side? This is a study that was done in 2016 that really modeled different ways in which we might approach the opioid epidemic strategically moving forward, and the ways that different strategies actually lead to different outcomes in terms of overdose deaths over time. The bad news is that the top line is actually what we would see if we didn't do anything differently, and seems to actually correlate to the trends that we're continuing to see. The good news is that the most optimistic scenarios, that bottom line that leads to 70,000 fewer deaths than the worst scenario annually by the year 2026, assumes that we're optimizing strategies in both reducing opioid supply, reducing opioid demand, and reversing overdoses, and stigma reduction, and other strategies that we'll be discussing. So one way of thinking about our goals in the California Opioid Safety Network is to really be that state that realizes that more optimistic scenario. So why it's important to reduce opioid supply? We all know that, and some of this, any of these materials that we go over today, if you might use them for your own safety coalitions, this is all material that you could use for your own communications in your own communities. This shows that from 1999 to 2010, we saw a dramatic increase in the amount of opioids being prescribed and a corresponding and linear increase in the number of overdose deaths and treatment admissions. We also see in geographic locations the same pattern. So places that have very high opioid prescribing also have high rates of overdose deaths. This is a map of New York City with all the boroughs, and it shows that Staten Island was a place that it was an outlier in terms of prescribing and also in terms of overdose deaths. We know that this epidemic is highly localized, even in the state of California. So the strategies that you adopt are going to need to be tailored to your own setting. So some of the things here that we discuss may apply and some may not. And this is designed to sort of help you see what might be most feasible for your setting. This is a study that came out in MMWR just last year that showed that when we're prescribing what we think may be short-acting opioids for acute pain, we may actually be setting the stage for long-term addiction. On the bottom axis, you have the number of days of opioid prescribed, and then on the vertical axis, you have the probability that someone will be taking those opioids 1 year after that prescription and 3 years after. And what we see is that even with a five-day supply, you have a 10 to 15% risk of taking that medicine 1 year afterwards. With a 10-day supply, it jumps up to about 20%. So 20% of people who are given a 10-day supply of opioids acutely are actually taking that medicine 1 year later. So guidelines that help, and safe prescribing practices that help reduce that number of first days are important. The same is true for opioid refills. The higher the number of refills, the higher the likelihood that people will be taking them long term. And then finally, 3 out of 4 people who use heroin are actually report using prescription opioids prior to the use of illicit opioids. So it's still, despite the fact that we're seeing more and more illicit use, and we've made a lot of success in terms of reducing opioid prescribing, we still have a lot of room to move in terms of continuing to promote safe prescribing. So how did we get here? This is, I think, familiar to many of us who worked in healthcare. I was in medical school from 1995 to 2000, and I certainly was taught that pain is the 5th vital sign, which was a way in which pain was marketed by the American Pain Society. On the left here, you have actually the the amount of money that produced pharmaceuticals actually invested in marketing OxyContin, and we see that there was more than $100 million invested in just the marketing of that one product once it was approved for the management for chronic pain in 1996. And we're promised in this middle slide here that Vicodin will help our patients become muscular and strong, and if not clothed. And it also, interestingly about this Vicodin as it sort of points to the convenience of this medicine. It says this is the strongest analgesic you can phone in. It doesn't require a triplicate, sort of pointing to the convenience and the way in which convenience actually leads to choice around prescribing, which we'll get to in a bit. So how do you know what your current prescribing patterns are in your jurisdiction? Many of you may be aware of the California Opioid Dashboard. This is a tool that anyone can, hopefully, even if you just Google California Opioid Dashboard, it would be the first thing you would come up. And it shows when drop-down menus, by county, the prescribing rates in a variety of ways. One is on the left here, you have the number of people taking very high doses, above 90 morphine milliequivalents per day. So these are the chronic high-dose opioid users. It also shows the number of milligrams of morphine actually dispensed into the community as a whole over time. And then for future Boots on the Ground webinar, we'll be talking about medication-assisted treatment and reducing the demand. And there's info on the dashboard for your community in terms of buprenorphine prescribing, and many coalitions are working to increase bup prescribing. And then for the last Boots on the Ground, we'll look at this element of the dashboard, which is the number of fentanyl deaths over time and the number of overall drug overdose deaths when we talk about increasing access to naloxone. So just putting a shout out for, putting a tab to the, your favorites to the dashboard so you can actually see your opioid prescribing patterns over time, and it's automatic. You don't have to do anything. It's automatically done by California Department of Public Health for us. So the first strategy that we're going to get into is safe prescribing guidelines. So I noted about half have instituted safe prescribing guidelines. There are many different guidelines available to us. There's this national level guidelines with the CDC, the state, California Board of Medicine has put out guidelines. Health plans and like partnership health plan or health systems like Kaiser have their own guidelines. And then there are guidelines by specialty. The occupational medicine doctors have their own safe prescribing guidelines. Dentists have guidelines. And then an individual facility, for example, an FQHC, might have their own guidelines. So what into that space would be the added value of a set of coalition guidelines? I think there is actually a lot of value, and many of the coalitions have recognized that, and we'll talk about that. Guidelines are sort of an important but the least strong form of influencing prescribing behavior. The use or adherence is generally voluntary. Guidelines use influences practice norms, so it sets a standard for what would be accepted as normal and the standard of practice for a given community. Guidelines influence clinical decision-making, but don't force clinical decision-making. Guidelines also, in terms of the coalitions, what we find is that because of that geographic specificity around prescribing that we saw in Staten Island and other places, guidelines offer us a regional opportunity to set regional norms. So in Marin County, for example, we have 3 hospitals, 3 emergency departments, and our guidelines allow us to set the standard for across all 3, so that a patient might come into one emergency department and recognize that they're going to get essentially the same standard as they would get in another emergency department. So across the systems within the region, it establishes local norms. And the process, as important as the product, I think, for local coalitions in terms of guidelines, is the process of developing guidelines gathers stakeholders together in the sort of necessary dialogue and relationship building to strengthen the coalition and formalizes partnerships that will be valuable to us in our work beyond the guidelines. This is just an example of guidelines that are available that we developed here in Marin County. On the left, we have our emergency department guidelines. Actually, on the left, it's our chronic pain management guidelines for outpatient settings. And on the right, there's our emergency department guidelines. These are actually available in an editable form. One of the benefits of the Boots on the Ground series is that we'll be making available to all of you some of these resources that we're showing. So you can actually get and download and edit and change the logos of any of these products in your own setting. This may be familiar to Casey. This is just the power of coalitions in prescribing guidelines. These are prescribing guidelines for the Monterey County Coalition and some of the settings in which the guidelines were adopted. So the next stronger element of influencing prescribing and safe prescribing is around decision support tools. So decision support tools support adherence to things that have been decided as important within the guidelines. The examples include electronic medical records flags, where flags might be around high doses or risk recombination. So if someone is taking an opioid and a provider chooses to also prescribe a benzodiazepine, there would be a flag that might come up and say, are you aware this patient is also taking an opioid? You might consider an alternative. Also, flagging risk factors for misuse. So if a patient has a substance use history, it would actually be featured prominently within the EMR as the patient is as the physician is ordering medication, so that you're able to take that into account. Another form of decision support is defaults to lower doses. For example, in the Kaiser system in Marin, the default for some of the short-acting opioids changed from 30 tablets to 15 tablets just by changing the drop-down menu available to ER physicians as they're prescribing. This is actually, unfortunately, embarrassingly powerful as a way of decreasing opioid prescribing because of what we know about the way physicians make decisions is often based on what's convenient and immediately available to them and what is suggested by the tools they have. And Casey will talk about how they're using decision support tools in Monterey. The other important decision support tool is cures. So one of the main strategies that many of the coalitions have adopted is trying to promote the cures use among their physicians. Cures, as most know, is our physician drug monitoring program for the state of California. It allows any clinician to see the opioid and other controlled substance prescribing history for any patient they may be considering prescribing to. This is what the patient activity report looks like. Basically, any physician who's registered in Cures can just look up by name and date of birth any patient's prescribing history with regards to controlled substances. And what you will generate through that is the patient activity report, which is just this basic spreadsheet that has each prescription that patient has received, and it will tell you what the drug name was, the dose, the other prescriber who prescribed it, and the pharmacy that it was filled. Using Cures is important, it's one of the core strategies that's being sort of advanced nationally. And this is a study out of Massachusetts that shows that areas where patients were doctor shopping correspond very highly to areas where there were overdose deaths. So we can, on future webinars, if people are interested, talk more about how specifically we can incentivize and get the best Cures use and get the best use out of that system. We'll now talk about policies and protocols. This is the strongest way of influencing, prescribing, because it's actually removing it from the domain of physician choice, but making it actually sort of a forcing function for adherence to those practices that we know to be the safest in prescribing. For example, formulary changes. Partnership Health Plan removes Xanax from their formulary. We know that many people who overdose are overdosing on combinations of opioids and benzodiazepines, and Xanax was pulled from the formula. Xanax is a short-acting and highly addictive benzodiazepine. So taking that example, we might think of an approach to preventing benzo opioid co-prescribing might be in guidelines, sort of mentioning that as a risk, and physicians, as we have in our guidelines, physicians should be aware of the risk of co-prescribing and take this into account in their prescribing behavior in sort of a more vague way. In the decision support tools, we might have the prompt that would say, if you're trying to order 2, that it would actually suggest that you pull an alternative in more real time as you're making that decision clinically. And then the strongest would be just not allowing some of those decisions to be made unless there's a special process like a prior authorization or a special request to have a formulary change. The final element around policies would be legislation. So as an example, Cure's use is currently in more of a decision support mode because it's a choice. So physicians can choose to participate or not. Cures will be mandatory starting in 2019 once they authorize the use of Cures. So Cures will be moving from decision support into a policy space in the next year. The next way that we would be so those are the tools that might apply within a clinical setting for helping physicians prescribe safely. The next tool available to us as a coalition is academic detailing. So this is something we had been doing in Marin County in terms of just educating our providers. It wasn't until later that I realized there's a special term for this, which is called academic detailing. And it's essentially borrowing the methods that we know were effective for our pharmaceutical representatives who would travel around to different clinics and educate clinicians specifically about why they, to try and influence their prescribing practice. It focuses on outreach and education to providers. We recognize that a high volume of opioids come from a small number of prescribers. So in Marin County, for example, we have about 80% of our opioids come from 15% of our providers. Many of them are orthopedic surgeons and certain primary care clinics. So we actually were able to pay specific visits to those settings and talk to them about prescribing behavior, give them some of the data, and do sort of a more tailored message to that particular group based on what we know about their prescribing practices. We also know that dentists, for example, are the highest prescribers to people aged 15 to 19. We can reach out to our dentists and let them know about the unique features of sort of the adolescent brain and risk of addiction at that age based on their prescribing to people, having wisdom teeth removed as a form of academic detailing. Also sending letters to different providers, educational forums, grand rounds, CME brown bags, and we can share some of the presentations that we've offered and different coalitions have offered in grand rounds or CME settings to their local providers to give a sense of what the most effective messaging is. Another way to reduce supply that we don't often talk about, but I've noticed on the poll that there are actually 17 of 39 who were actually involved in drug disposal and take-back, which is encouraging, is not just reducing the inflow, but also increasing the outflow of medicines from our community. Misused medications we know often come from family and friends, especially in young people. There's a SAMHSA study that said about half of the medications that young people were misusing were first obtained from family and friends through informal networks and not from physicians. So by reducing the number of opioids that are in our medicine cabinets, we can actually help address the opioid epidemic locally through offering people opportunities to get rid of unused and unwanted medications. This is an example from our report card here in Marin County, our little dashboard that we use to track our progress that shows that we had, we're trying to increase the number of the pounds of medicines that are actually returned in our newly established take-back system with a SMART goal of a 10% increase annually. And this 2017 data is partial. So we haven't had the whole, we don't know what we did in the last quarter of 2017 yet. there are a series of, there are a number of counties now that have actually entered into a relationship with pharmaceutical manufacturers for them to fund a network of take-back locations through local ordinances. This is something that has been proposed at the state level and has not been successful in terms of a state-level legislation in the state of California, but many jurisdictions have been moving forward independently on this, and that number continues to grow. And I shared our local ordinance with Amy, and we can with this COSIN, and you can find it on the website if anyone's interested in learning more about how we might pursue take back at the local level. This is what our little website looks like in terms of the guiding people to locations for take back. We have now 25 locations across the county funded by pharmaceutical manufacturers. So another piece of reducing supply is actually working more effectively with our law enforcement partners as we get deeper into this illicits as a potential source of opioids. This relationship will need to continue to grow. Obviously, the Federal Drug Enforcement Agency investigates very high prescribers and pill mills. Locally, though, we can actually have stronger relationships with our local law enforcement, even in terms of reducing supply. Examples are district attorney letters that can actually go from a district attorney as people are arrested for illegal use of opioids, and sending those letters to prescribers to let them know that a patient of theirs was arrested for selling medications. And then coroners, some jurisdictions, the county coroner or medical examiner will actually send a communication when someone has died from an overdose to the prescribers they find in the cures report who had prescribed to that person, non-punitively, just to let them know that they might want to take that into account in their future practice. This is an example of the letter that we have in Marin County, where our district attorney basically says, dear physician, it's come to our attention that X, your patient, a criminal complaint was filed against that person. It tells a little bit about the situation, and then it was a partnership between our team, Health and Human Services, the Partnership Health Plan, our Medicaid provider, and our clinicians, our different health systems, to actually reach back and just let them know. And we got generally positive feedback on this, because as we know, many times physicians that don't actually know what's happening with the medicines they're prescribing. So now we're going to hear, so that was just a quick review of some of the types of strategies that we might employ. Any one of those things would actually, for us to be successful in its implementation, would need some more specific technical assistance and working through the details and the relationships locally that are available to advance any one of these strategies. We just wanted to sort of give you an idea of the menu of options that would be available. If we're pursuing 2 or 3 of these things at the local level, we're very likely to have a lot more success in terms of reducing opioid overprescribing. We're going to hear now from 2 different coalitions who are advancing 2 different ways of promoting safe prescribing. The first will be from Casey Grover. Casey is an ER doc and a friend and an awesome champion in this space for, across the state. He and his wife, Reb Close, are working in many sort of progressive ways in Monterey County, in safe pain management from emergency departments, but also in connecting people to medication-assisted treatment from the ED. And some of their safe prescribing patterns are what we're going to hear about today in terms of some of the decision support tools. Casey's been working in Monterey County at CHOMP since 2013, and he's the chair of the Division of Emergency Medicine. So I'll hand it over to Casey now.
All right. Is the audio okay?
Yes, we can hear you.
We can hear you.
Wonderful. Wonderful. Thank you so much for having me, and I am honored to be a part of this event. This is just fantastic that this is so well presented, and I'm, again, grateful to be able to participate. So in Monterey County, we have a unique mix of hospitals, and I work at the private hospital in the Monterey Carmel area. And for the longest time, we've known that there's been a problem with opioids, and we've started working since 2005 and 2006 on trying to address chronic pain and opioid misuse. And one thing that has been very interesting to watch is, as we would tell our colleagues, please don't use opioids, or can we please reduce opioids, the response was, that's fine, but when the patient's in pain, I have to do something. So can you please give me some options? And the other thing that also came up is, as we all know, physicians tend to get pretty stuck in their ways, and change can be difficult. And so we tried to brainstorm ways of, number one, what can we do to expand options for pain management? And number two, how can we make the right decision the easy decision? And I apologize, I'm in the hospital, so if you get an overhead page, I'm sorry. So looking at our first intervention, and I can't take credit for this as an idea, it was actually our department director who was trying to make us work faster, but we have pre-printed scripts. So in Monterey, we're still using paper prescriptions, and when the paper prescriptions are blank, it takes the same amount of time to write for naproxen as it does for Norco. You have to write up the name of the drug, the quantity, the directions, sign it. And so our director realized, well, we use a ton of medications on an ongoing basis, antibiotics, medicines for allergic reactions. Why don't we just make a pre-printed script, which you can do for non-scheduled medications? So this is a zoom in of what's in our pain and nausea section. And it used to be that when people came in with a sprained ankle, it was just as easy to write for Norco, as again I said, as it was to write for naproxen. But now if somebody strains their back, with 4 check marks, I can give them naproxen, Flexeril, Lidoderm, and Voltaren, which gives them 4 options for pain management without any opioids, and it's actually faster than writing for an opioid. So regrettably, because we have paper prescriptions, it makes it very difficult to track the changes in outpatient prescribing from the emergency department. But I know personally, now that I can go check, naproxen, Flexeril, Lidoderm, Voltaren, that's my default. I rarely write for opioids unless I specifically have to take the time to get out the blank prescription pad and write for it. So again, this was an example of, number one, giving people better options for non-opioid therapy than just Motrin and Tylenol. And number two, also making the easy choice the right choice. The second thing that we also worked on was trying to come up with order sets for pain management. And this comes back to the same thing of we'd have a migraineur in the ER, and they didn't feel that much better with Toradol. And the providers are saying, well, the patient's in pain. You tell me not to use opioids. I have to have other options. So I sat down with one of our hospital pharmacists, and we created a pain management order set. And I apologize for the font being small, but I can walk you through it. So I basically created first-line therapies, which were non-opioid, second-line therapies, which are the opioids that aren't as desirable, and then the third-line opioids, which are the ones that people seem to like the most with issues with chemical dependency. And as the group probably knows, it's Dilaudid and oxycodone that we were trying to stay away from. So up here, and the first red box on the top is first-line oral medications, and that includes oral anti-inflammatories and acetaminophen. The second box is to highlight then the category of injectable, either intravenous or intramuscular pain management, and that predominantly is ketorolac. We do carry intravenous acetaminophen, but our pharmacy wanted us to not have that as a standardized order because it's relatively expensive just yet. And then this third box is all migraine medications. And what's incredible is, I don't know if I can count, but there's probably 15 plus medications there. And I have to give credit to one of our ED pharmacist, Brian, for this, because he went through and basically did an evidence-based research of the literature to find out which are the most effective medicines for migraine that are non-opioid. And so we have dexamethasone on there, we have sumatriptan, rizatriptan, we even have DHE, we have valproic acid, and so we've really been able to avoid going first line to opioids for migraine. And so it's great. It's a single order set. The physicians all know where to find it. And it's fantastic that we can have folks look at this order set and choose a non-opioid option. This is the second part of the this is the second part of the pain management order set. And the first box is to highlight adjunct therapies. And this was something we were doing with things like topicals, things like prednisone for radicular pain. We even have transcutaneous electrical nerve stimulation or TENS units. I can ask my staff to set up for a nerve block. We have nitrous oxide. Same thing, just trying to make the non-opioid options available. And then lastly, we also have a low-dose ketamine infusion set, and we've tried to use that for more special patients who don't respond to really any of the other therapies, and we have a protocol written up for that for our hospital. And just going forward one slide, you can see I'm highlighting two medications that have been extremely helpful and very well received by patients, and that's lidocaine patches, the 5% lidoderm, and then the topical diclofenac, the 1% Voltaren gel. And as a patient, I used some Voltaren on my knee this morning. It works absolutely fantastic. And looking at how that's actually been received by our emergency department staff, here's a comparison of 2012 to 2014 versus 2014 to 2016, and looking at non-opioid therapies. And you can see we've increased our use of lidoderm by over 300%. I realize gabapentin has some issues, but we've certainly increased our use of this as well. And just to clarify, these are doses given in the emergency department. And then we've also increased our use of Toradol and ibuprofen. So to kind of take home the point, if you give physicians the option, at least in my emergency department, and hopefully that's applicable elsewhere, they use them. And I can't tell you the number of times that lidoderm patches have been great in people over 85 or even in their 90s who have fallen, compression fractures, contusions. They've been great. And lastly, this is from the California Opioid Dashboard. This is a number of the opioid prescriptions by patient location, and you can see Monterey counties in blue, and we're seeing basically a slow downward trend as compared to the state average, which is relatively constant. And in our county, we have 4 hospitals with emergency departments. Mine is where our drug safety efforts have really started and are being led from, and it's great to be able to develop something, have a protocol, talk to my buddy who's, 30 miles down the road in Salinas at the neighboring hospital, share it with him or her. We've really had the please steal what we are doing approach to this, and we've had some interest from the other hospitals who are slowly starting to develop the same approach. As an example, one of our county hospital for the county of Monterey doesn't even have buprenorphine on formulary, so they're working on that whole pathway, and they're asking our pharmacists and me and my staff, and we're sharing protocols and helping them to move forward. So it's truly an effort that will spread throughout the county.
Thank you. Can you hear me?
Yep.
Thank you, Casey. That was excellent, and I hope that you can stay with us for the discussion, which will follow.
Looking at the ER, it looks pretty good. So I'll be here.
Here. Great. Just a little more Voltaren. They can wait a little longer. All right. So the next speaker will be James Wilson. James will be coming at this from another perspective of a rural coalition in Northern Sierra up in Plumas County. James has been one of the early leaders in coalition space, and really has been championing a lot of the work that's happening up in the Northern Sierra region. He's the leader of the 4-county coalition, which spans Plumas, Lassen, Sierra, and Modoc. They've done a lot of excellent work in reducing the amount of overprescribing and reducing opioid overdose deaths, and they're working across the spectrum of care, incorporating prevention and harm reduction principles. So I'll hand it over to James.
Hey, can you hear me okay?
Yep.
All right, great. Well, thank you so much, Matt. I'm honored to be here. I'm honored to be able to present this. Move the slide a little bit forward. So I wanted to just first off just talk about a little bit about our coalition and about the region that we have. As Matt pointed out, we're a 4-county coalition. It's Modoc, Lassen, Plumas, and Sierra. It's actually a really big area. It's really spread out. We joke about how it could be its own state, and it's really actually the size of Maryland, but it only has 1% of the population. So that kind of gives you an idea about how spread out, how rural it really is. We even call ourselves more of a frontier area than a rural area. Well, in this large area, there are 5 hospitals and just about a handful of different clinics. And these clinics are operated mainly by the hospitals that are located in Modoc, Lassen, and Plumas County. But there's also some clinics that are operated, for example, Sierra County has 2 clinics, one operated by a hospital out of Plumas and one out of a hospital out of Nevada County. So we started this work I'm going to be talking about the guidelines and implementing just a regional universal guidelines that we all kind of agreed upon. We started doing this work out of the public health office here in Plumas County. This is where we actually processed the death certificates for our county, and we noticed that there was, just a really high rate of overdose deaths. At first, when we were taking a look at it, we thought that it was kind of a result of drug diversion or illicit use. And on closer look, a lot of these folks that were dying, and they also had really high prescriptions themselves. So if you look at this is a graph of all 4 of our counties, Plumas, Lassen, Modoc, and Sierra. And it shows over time, over a 6-year period, what our prescribing rates were. We compare it to California's rate, which you can see California as the line at the very bottom in yellow. And California, although it's risen, it's been staying somewhat steady as far as the number of prescriptions per 1,000 residents. It's been a little bit between like 600 and 700. If you go up, the line in red at the very top is Plumas County, and it was seeing the highest prescription rate. Correlating with that, it was also had the highest overdose death rate. And so we really figured out that we needed to do something. Well, in that line that's there, the big black line, that was when we started realizing that this wasn't due to diversion, but it was due to prescription, and it was when we realized we had really, really high prescribing rates and needed to do something about it. So that's when we formed our coalition. This black line. And you can see there was some work that was done before that, but for the most part, our rates were pretty much doubled what the states were. We were prescribing, 1,300, almost close to 1,400 prescriptions per 1,000 residents. So we decided we needed to do something, and one way to do it was just, dramatically drop the number of prescriptions. I showed this graph to a doctor in our region, and he thought that maybe it was just due to a handful of high prescribers that have since moved away. But the docs that he was referring to just moved away to a different county in our same region. So it didn't really affect it as much, especially since there's a cross-correlation of patients going into our, neighboring counties, hospitals, and clinics. You can see that once we did start doing something about it, once these guidelines were put into place, there was a pretty dramatic drop between 2015 and 2016 in the amount prescribed. We started out, when we formed the coalition, we started out with one of our action teams was the Safe Prescribing Action Team. And this was really kind of like what I like to refer to as the doctors club. It was comprised completely of doctors and myself, who is not a physician, and it included physicians from just across the region. So we had representation from all the major hospitals and a lot of the clinics. Our main objective that we decided upon was to put prescribing guidelines in place in every hospital of our region. And these were going to be guidelines mainly for chronic pain. It was actually, when it came to the emergency room guidelines, we were able to kind of quickly decide upon what guidelines looked good. For chronic pain, we originally looked at 2 local guidelines. One of them was in place. It was from Eastern Plumas Healthcare, and then Plumas District Hospital had some guidelines that it was looking at. It hadn't completely implemented them yet, though. We also looked at Marin's guidelines and San Diego's, and there was a lot of discussion amongst the providers from the action team just about which guidelines that we should actually universally agree upon. I actually looked back at our minutes from these meetings, just getting ready for this, and there was just so much discussion about the tiniest details. As a non-physician, I didn't really understand what the big deal was, and it was also kind of frustrating. I figured that we could just grab any guidelines and put them into place. Well, part of the problem was, I think that each hospital was linked to its own town, which was geographically and culturally just very separate and very different from the other towns and regions and hospitals in the area. So each one of them wanted to kind of maintain its own unique sense of autonomy, and guidelines was one way that it was able to reflect this. It was around the same time that when we're looking at all these and arguing about which ones would work, the CDC released its recommendations for guidelines. This was around the beginning of 2016. And partially was, I think, maybe because it was the authority of the CDC being something that was already universally accepted as, an authority figure. It was just agreed that it was kind of a good middle ground for all the different guidelines that we were considering. And it just, the conversation about just what details should be included and which ones should be omitted just ceased completely. And these guidelines were regionally accepted and aligned. So it really saved us a lot of trouble. There was some posters that were already ready to go. We just had to download them and print them up. So we were able to print those up and put them in all the hospitals and clinics. And ever since then, that's just been basically the ones that were followed. And that's the story of how we got our guidelines in place.
Great. Thank you, James. And James will be available for the discussion as well. So getting to available tools and resources, this is a graphic that represents the diversity of partners that come together in an opioid safety coalition, and it's something that any of you should take advantage of in your own internal communications in your community about what a coalition might look like when it's actually truly intersectoral and engaging all the partners that we might engage. In the development of guidelines, obviously healthcare providers, hospitals, and clinics are the most important partners, and even recognizing the diversity within counties around those players. Having the public health department engaged and helping sort of support those conversations is wonderful. It's really helpful to have an agency like a coalition who can serve outside and above all of those other independent players in order to actually serve as the convener for that conversation James is describing. When you're having the nickel and dime conversations about whether or not you should set cutoffs of 90 milligrams per day or 100 milligrams per day, those are obviously not natural conversations to one system versus another. Those are things they would not necessarily, they're internally perfectly satisfied with their standards. So we need, the coalition unique role is to actually gather partners together to come up with what we consider to be, as a community, our standard moving forward, and bringing together the diversity of players in the coalition space helps offer that kind of unifying lens. So let's see, how do I move to the next slide? Sorry. Did I go to get to the stop? I'm sorry. If everyone is seeing what I'm seeing, we're back at the beginning. And I'm going to move to the next slide, which will offer the resources that we have available to us.
We'll put that back up, Matt, in just a second.
Yeah.
There we go. Great.
Tools we'll make available. Okay, so these will be, Karia and Amy can talk more about this. There will be, an ever-growing sort of resource bank for coalitions around specific tools. We know that most of us don't have the bandwidth to build these things from scratch, and there's actually a lot of, thus far, mostly informal sharing and plagiarizing and liberating content from one another. I call Casey and Reb on a regular basis to ask what they're up to and just take their things. We can actually make that a lot more efficient by just having them in a centralized location in the Accelerator webpage. So some of the things that we're going to make available out of this conversation include coalition guidelines, the sample order sets for Monterey, some of the formulary change announcements like Partnership Health Plan in terms of when they remove Xanax and Soma from the formulary. A Cures promotional video has just been completed that's about 3 minutes long and can be used. It's geared towards clinicians and can be used in any of the presentations you may offer to clinicians in your community. It just sort of sets the stage, and it's introduced by the California Department of Public Health Director, Karen Smith, sharing patient agreements and contracts, PowerPoint presentations that sort of set the stage for the local burden using the dashboard and then pivoting into some of the safe prescribing messages for local providers. The local safe disposal ordinance, Marin counties is already available, and we can solicit those from other counties as well, and then sample letters from the DA and coroner. Those are some of the things that if any of you choose to move forward with any of these strategies, you can look forward to having those resources available and have them customizable for your local area. And I think that's the end of my bit, and we'll move into the discussion.
Great. Thank you so much, Matt. Very